All right, let's get into it. Today, we're going to tune in to one of the most fundamental skills in nursing. It's part art, it's part science, and it is absolutely crucial for your exams and, more importantly, for your future patients. We are talking about auscultation.
So think about this for a second. What if you could actually detect heart failure or a dangerously narrowed airway with basically nothing more than your ears and a stethoscope? I know, it sounds a little bit like a superpower, but honestly, that's the real power of skilled auscultation.
So, what are we really doing when we auscultate? Well, you can think of it like you're eavesdropping. We're listening in on the private conversations happening inside the body, between the heart, the lungs, even the gut, to pick up on critical clues about a patient's condition. It's a foundational skill, and mastering it, that's just non-negotiable.
Now let's talk about your most important tool here, your stethoscope. It's not just one thing. It's got two different sides, and they each have a very different job. You've got the diaphragm, that's the big flat side. That's for your high-pitched sounds, like the normal lub-dub of the heart and most of your lung sounds. And the key here is to use firm pressure. Then you have the bell, that smaller cup-shaped side. That's for the low-pitched sounds, like some abnormal heart murmurs or brutes. And for the bell, you're going to use light pressure. So remember, firm for high, light for low. It's a simple rule, but man, it makes all the difference.
Getting a good, clear sound isn't just about listening. It's also about the setup. I like to think of these steps as a little ritual to get it right every time. First, find a quiet spot. Yeah, that might mean turning off the TV. Next, just tell your patient what you're doing. A huge one for infection control, clean your scope. And start with the earpieces. Make sure those earpieces are angled forward, kind of toward your nose, so they line up with your ear canals. And finally, a simple act of kindness. Warm up that diaphragm on your hand. Nobody likes that shock of a cold stethoscope. Okay, let's talk about something that gets super confusing when you're in your clinicals. You're taught in class to do things one way, and then you're on the floor and you see a senior nurse listen right through a patient's gown. And look, this quote, it acknowledges that reality. It happens, often for good reasons, like preserving a patient's dignity or just saving time. But the big question is it the right way? So what's the correct answer for your NCLEX? And more importantly, for your patient? The evidence is crystal clear. You have got to listen on bare skin. That rustling hospital gown, it can create sounds that mimic lung crackles, and that can totally throw off your assessment. So be respectful, use draping to maintain privacy, but for an accurate assessment, that stethoscope has to be on the skin, period.
Okay, so where exactly are we supposed to listen on the chest? Well, there are 5 key spots, and lucky for us, there's a fantastic mnemonic to remember them. APE to man. That's aortic, pulmonic, Erb's point, tricuspid, and mitral. You have to pay close attention to these landmarks, the intercostal spaces, the sternal borders. Think of them as your roadmap to the heart's valves. You've got to know them cold.
So you've got the map. Now how do you use it? The most important rule here is to never listen randomly. The whole point of this is comparison. You've got to move methodically, kind of side to side in a zigzag pattern, and you're constantly asking yourself, does the left side sound exactly like the right side? Any little difference, any asymmetry, that's a huge clue that something might be wrong. Before we can even begin to find the abnormal, we have to be masters of what's normal. And the normal soundtrack of the heart is that classic lub-dub. S1, that's the lub. It's the sound of the mitral and tricuspid valves slamming shut. That's the start of systole, when the heart is squeezing. Then S2, the dub, that's the aortic and pulmonic valves closing. That marks the end of systole. S1, S2. Lub, dub. That right there is your baseline. All right, listen up, because this is some high-yield NCLEX territory right here. Sometimes you'll hear extra sounds, and we call these gallops. An S3 comes right after the dub, so it sounds like lub, dub, da. A good way to remember it is to think about pouring water into a glass that's already full. That slosh you hear, that's the sound of an overloaded ventricle. It's a classic sign of heart failure. Then there's an S4, which comes right before the lub, so it sounds like ta, lub, dub. This is the sound of the atria struggling to push blood into a stiff, non-compliant ventricle. Both of these are major, major red flags. And yep, the list of abnormal sounds keeps going. A murmur isn't a beat, it's more of a whooshing or blowing sound. This means there's turbulent blood flow, usually because a valve isn't opening or closing the way it should. Then you have something called a pericardial friction rub. This one is super distinct. It's a scratching sound, almost like sandpaper rubbing together, and it's caused by the inflamed layers of the sac around the heart, rubbing.
So let's just put this all together. What's the bottom line every single time you listen to a patient's heart? You are looking for one thing and one thing only: a clear S1 and S2 in a regular rhythm. Anything else, any murmurs, any gallops, any rubs, or an irregular beat, that is an unexpected finding. And that means you have to investigate it and you have to report it. That's your mental checklist every single time.
Okay, now let's switch over to the lungs because the same principles apply. See, what's normal in one spot is actually abnormal in another. Over the trachea, you expect to hear these loud, high-pitched bronchial sounds. But as you move out towards the edges of the lungs, the peripheral fields where all the gas exchange is happening, that sound should get much, much softer. It should be a low-pitched, breezy sound that we call vesicular. Adventitious, it's just a fancy word for abnormal. Let's start with the two most common ones you'll hear. First, crackles, which are sometimes called rails. They're these popping, discontinuous sounds. The classic way to describe it? It sounds like rubbing strands of hair between your fingers right next to your ear. That sound means there's fluid in the airways, like you'd find in pneumonia or heart failure. Now, wheezes are the opposite. They're continuous and kind of musical, like a high-pitched whistle. That sound means narrowed airways, which is the hallmark of something like asthma. Okay, two more critical sounds you absolutely have to know. Raunchy are low-pitched, continuous sounds, and they're often described as sounding like snoring or gurgling. They're caused by secretions hanging out in the larger airways. But stridor is in a league of its own. It's a loud, high-pitched sound you can hear on inspiration, often without even needing a stethoscope. It signals a severe upper airway obstruction. And let me be clear, it is a true medical emergency. If you hear stridor, you need to get help immediately. As bad as all of those other abnormal sounds are, there is one finding that is even more terrifying, and that's silence. A complete absence of breath sounds where you expect to hear them could mean something like a collapsed lung. It is a life-threatening emergency, and it requires immediate action. This is where great nursing assessment really goes beyond just listening. You have to be able to connect the dots. So, for example, if you suddenly hear localized crackles in the lungs, what could be causing that? Well, one scary possibility is a pulmonary embolism. And where do those often start? As a DVT, a clot in the leg. That's why your assessment doesn't stop at the chest. You also have to be looking for signs like unilateral warmth, redness, and swelling in a patient's calf. Let's build another clinical picture here. Let's say you hear that S3 gallop. That points to fluid overload. You also hear crackles in the lungs. That also points to fluid. So, where do you look next? The periphery. You're going to check for edema by pressing on their skin, usually over a bony area like the shin. This chart here gives you a really clear, objective way to grade what you find, which is so important for good documentation and for tracking if your patient is getting better or worse. And now, let's put it all together. This is how you take what you found and turn it into a professional note. Just look at the difference here. The expected note, it's clean, it's simple. But the unexpected note, that tells a story. It connects the S3 heart sound to the crackles in the lungs to the +2 pitting edema in the legs. This is where you synthesize all your assessment skills. You're painting a clear clinical picture of heart failure. So I want you to remember this the next time you pick up your stethoscope. It is not just a tool. It is a direct line to the story being told inside your patient's body. A story of health, a story of struggle, maybe even a story of an impending crisis. Mastering this skill means you can actually hear that story and you can understand it in a way that truly changes outcomes. So, are you ready to listen?